I think it's early days and it's exciting time. We have 2 approvals in the field for lymphoma for twice relapsed large cell lymphoma, a third contender. But we're all transplanters, or many of us are transplanters here. Does this have the potential to actually replace transplant?
So that's a great question, and I think that's becoming the burning question. And I think we'll talk some more about this. But there are trials that are addressing your question exactly. That is, there are randomized trials ongoing now that look at patients who have had either recurrence within a year of R-CHOP with large cell lymphoma, or who are, that is a relapse group, or who are refractory, primary refractory. And they're being randomized now to either CAR or standard therapy, which is chemotherapy followed by autologous stem cell transplant. And there are three trials now. I think the Novartis group is going to be doing the Belinda study, the Zuma 7 trial from Kite, and then the Transform study from Juno. And those are almost identical studies which are going to address that question. I think we don't know the answer to that yet.
I think we need to be careful, though, as we pick patients, because we know that majority of lymphoma patients can be cured with upfront chemotherapy. And we know that if someone has a relatively late relapse and is highly responsive, maybe they don't need CAR, especially if they're incredibly expensive. But picking the right patient population for CAR T cells is going to make a big difference going forward.
And I think the way the 3 trials are, they've really honed in on the highest, obviously primary refractory large cell lymphoma is a very concerning, even if you relapse within 1 year of primary induction therapy. So I think that the population that's being studied right now is kind of an appropriate question with the data that we have from the ongoing and commercial trials that led to commercial approval.
But I was struck by, if you take 100 people with relapsed large cell lymphoma, we don't cure very many of them with a transplant. At the end of the day, it's about 10. That means about 90 of those 100 patients fail somewhere along the line. They either don't get into remission and can't get to a transplant, they actually get to a transplant but then still relapse, right? And so there's a tremendous opportunity for the CAR products to potentially win in many avenues of this.
Well, I've been amazed actually at the number of people who are coming in and talking about CAR T cell, and you're trying to talk to them about second-line chemotherapy and a transplant. And I kind of go, it's a fluid conversation in that situation where, okay, we can talk about CAR T cell, but there are going to be patients, who are a PET negative CR that, I think based upon that response should get the opportunity to go to transplant still in 2018.
So what we know about long-term durability is only out to about 2 years. I guess we're still hopeful that that's going to result in long-term disease-free survival.
Since we see not too many relapses between the 3 to 6 months and the 2 years, we can be hopeful that when it goes up to 5 years, that drop-off is very early, and after that the lines are plateaued. But I think the important thing which I felt is does this relate to persistence of CAR T cells? I think in the Zuma 1 2-year update, there were patients who did not have persistence of CAR T cells but still were in a CR. But if you think about it, that's a very interesting question. We are thinking of more of an immunologic effect over here, but you don't necessarily may not need to have lifelong persistence of cells. When we transplant patients, we don't have lifelong persistence of beam or things like that, and still a percentage of patients are cured. Here it's possible that even if you don't and you got enough in the early period to kill off those resistant lymphoma cells, you may have a durable response.
So I think the hope is warranted and it's appropriate, but I think we also need to keep in mind that this is an entirely different type of therapy. And so we're basing our assumptions based on our chemotherapy data and our transplant data. But CAR T cells may be different. So we've got to get them out longer to really be sure.
The way I like to think about this, and the way I discuss this, at least with patients, is to talk about first autologous transplant and the data with autologous transplant, to talk about allogeneic transplant, which in every case I would actually prefer because the data in control of the lymphoma is better for allogeneic transplant versus autologous transplant, except for graft versus host disease, which is the limiting toxicity, and the mortality is the reason that allogeneic transplant overall is not better. But the way I think about this is as an allogeneic transplant without the graft versus host disease. And maybe that's scientifically not exactly right, but I think it's similar.
So these approvals are in aggressive lymphomas. What about some of the other histologies? Do we have any data?
Well, I think there are some enticing data from Steve Schuster in the Penn data from using the Novartis product and their own product in follicular lymphoma, and I think you have some data at your institution in follicular lymphoma.
Yeah, we have data with JCAR14, which is a precursor to the JCAR17, and there we see high incidence of complete remissions with very, very rare relapses. So again, with short follow-up, this appears to be tremendously exciting. I know a number of the companies are running clinical trials now. I think ZUMA-5 is the trial in follicular and marginal cell lymphoma with the oxycaptogene, and similar products are going on.